PV isolation is not compliant, how do we expect that to produce a perfect donut shape size every time in every antrum? Of course, that doesn't matter. I mean, it doesn't work that way. When it works well, sure, it works well. But I find more than half of the time when I do redo maps, it's not what we publish. It's what we really see in our labs on redos, is that they're not as pretty as we think sometimes. So I became a lot more focused on doing segmental isolations. And when we do segmental isolation, we mean that we accept the best fit, we do the best PV isolation or antrum modification that we can, but we have to make note of where is it not touching the best and extend that antrum modification so that we can produce the wide area circumferential ablation as much as we can. And the wider you make it, the more the modification. Right? If I'm doing a point-by-point ablation, I'm doing a larger atria. Do I always keep the same size, whether the atria is bigger or small? No, if a bigger atria, I make it bigger. When Dr. Miyazaki talked about this, we say, okay, yeah, all we have to do is shift the balloon and put it posteriorly, put it superiorly, that will extend the lesion. So this type of a large area modification became actually a very good way to extend out the lesion set and have a nice, ablated large area that potentially cover a lot of the triggers. So segmental isolation become a very important way to ensure a large antrum modification. So I would say, to instead of focusing on 4-vein isolation, get everything done in half an hour, spend the additional time to try to modify beyond just the conventional one shot, one isolation. That's kind of the first message. All right, next. So we started playing with this ever since 2016, but this published 2016, but this actually manuscript took a while to publish because everybody thought we were crazy to use a cryo balloon outside to create large areas. But as you can imagine, the large contact area, the contact of the freezing area to any side, as long as you have cryo balloon tissue contact, that interface will be around -70 to -80 degrees Celsius. That's not the tissue, that's not the return gas temperature that you see on the monitor, right? That's the mixed gas temperature when you get back. But as the refrigerant is sprayed to the anterior part, the interface is -80 degrees. So if you touch that on any surface, around 2 minutes plus, we found that you actually can have very large area modification in 2-3 minutes. So we found that to be very impressive. You can take one large area out at a time. So if it needs to be, it became something that we started playing around with to say, all right, can we spend minimal time, get the large area and modify it, right? If we're going to have focal ablation on someone with very large atria, we know posterior wall is an issue or roof is an issue. We do a roof line. And with cryo balloon, you can actually get a 2-centimeter line all the way across with something like this. So next. So this became our best practice 3 to think about what else to do. But we hesitated for a while. At least I hesitated for a while to write up the best practice 3 because honestly, I was very afraid that everybody would take the cryo balloon and just put it anywhere to just ablate and cause half dead tissue everywhere. So what I wanted to do, and when we talked to Dr. Ariana, he wanted to write up the posterior wall, that work that he did. I said, well, we can do that, but I want to focus on just how to not cause trouble and how to minimally spend time doing what's necessary. So the left atrial modification, extending beyond the pulmonary vein antrum, was what we want to focus on, guiding the operators what to do. And the ability to look at the ligament marshal area to modify that, as well as different roof area, posterior wall, And some people called me up yesterday even asking, are you going to talk about mitral valve and things like that? It's like, no, septum, everything, SVC. Yes, you can put cryo balloon just about anywhere to freeze, but number one is, can you do it safely? And two, is it necessary? So these are all the things that we can think about and talk about. Right, next. Next slide. Yeah. So you'll see nice slides like this all the time when we start publishing these things, right? To have, we can do a cryo balloon modification of the posterior wall. I'm not sure how many have tried this before, but does it ever look like this? Now you read this carefully. This actually says cryo balloon in conjunction with PVI and about 30% plus required RF ablation. Because anybody that tried this would know that it never looks like slide C or D to have a posterior wall that's nicely cut off at the back end. Because cryo balloon and sheath will not be able to do that. You always leave a little triangle in the back. So we can modify the cryo balloon, but I didn't want to call it a posterior wall isolation because to me, the posterior wall box isolation should really look like that. And that's done with the conjunction of RF ablation. So that's actually an important distinction on how to do it right. Okay, next. So how do I do this and when do I do this? I was like, well, I'll talk about it in the context of some patients I deal with. That's, these are real patients, and sometimes I will do different things for them. So I have a 55-year gentleman, persistent AFib, failed medical regimen, EF 40%, chest VAS 3, hypertension, diabetes, heart failure, and not a humongous atria. 4-vein isolation was done, cardioverted, no low voltage, no fraction of atria, and no spontaneous recurrences and ectopies. Would I do anything else? Right? A patient like that, 55-year-old, I probably leave them alone. Like get the high yield area done. You work on their comorbidities, make sure they don't have sleep apnea, and I'll probably just not take out more tissue than necessary because I can always go back. And unless they're a fractionated low voltage area, I probably don't want to cause more trouble. Then the same day, I have a 60-year-old female, persistent AFib, failed Sotolol, the same EF 40%, chest VAS 3, hypertension, heart failure, and being female. Not a huge atria. 4-vein isolation was done, cardioverted, but post-cardioversion, multiple ectopies, spontaneous runs of arrhythmias. So that's when I started thinking, okay, what does the substrate really look like? Do I have the 3D map capability to try to understand what's happening? All right, next. So for this patient, when we put a posterior achieve catheter, yes, it's low density mapping. As low density as they are, you put that in the posterior wall, and you see the achieve channel, and this is what the electrogram looks like. With a spontaneous runs of arrhythmia, or you're pacing at 300 millisecond, and atrial conduction looks like that. That to me this is actually very diseased electrical tissue and is set up for nice rotational activities since nobody wants to say rotor anymore. And the ability to eliminate these could be important. So if I'm doing RF, cryo, PFA, or any other energy source, I take out these areas because these are origins for sustaining and triggering arrhythmia. Next. So we actually were able to just do posterior wall, by pushing that against the posterior wall, segmentally isolate that. I think we spent probably another 10 to 15 minutes modifying those areas. And this is what we get at the end with the voltage map. So the posterior wall is done and segmentally isolated with the cryo balloon in the same single procedure. So that's when I started choosing when to do it, when not to do it. It really depends on the substrate, the patient, to see if it's worthwhile to do. Next. But here's the thing about posterior wall isolation and using cryo balloon or RF or any energy source, right? The number one thing we need to think about is, when we create a lesion, the best lesion is a nice transmural lesion. The second best lesion is no lesion. Right? So I've seen a fair amount of recurrences of my own even or others that have atypical flutters that we create. Right? So here's a roof line. You can clearly see where we try to create a line, but there's a gap. And that, if we don't take care of at the same time, will have atypical flutter. The nice thing about cryoballoon is that it's a nice white band, but if you move and do not overlap the lesions enough to create that roof line, you end up with atypical flutter. So if we see that post-ablation, we have to take care of that and make sure that that is done. Next. And this is the case, one of the cases I remember very well. Right? This is another incomplete roof line. The story of this one also kind of goes into how well we can see this. The last map you saw was Insight, mapping with a chief. A chief, as we know, is very widely spaced. Sometimes it looks completely dead in the roof or the posterior wall. You create a nice map, but it can be very frustrating because this is a lady that came from California for persistent AFib ablation. As you can tell, I did four-vein isolation and roof ablation. She actually, in California, a year later, had atypical flutter recurrence. And she went to one major center and mapped out with the CARDO system, Pentaray, and said that it was a posterior wall atrial tachycardia, ablated near the esophagus, couldn't terminate it, put her on amiodarone, and then send her out. She had a recurrence, right, very rapid, hard to control flutter, and then went to another major center with HT Grid, Insight, tried to map it out, came to the same conclusion. So they want an AV node and put a pacemaker in. And she called me up and say, she had recurrences of the flutter, and they want to put an AV node and put a pacemaker in, the AV node ablator. I was like, wow, that's flutter are curable. And so I said, well, let's do it again. And only to find out, it's my good friend that did the first, first center and second center, and I know they're very capable. So I really doubt, I was like, gosh, is it that difficult? Maybe I should just let them do the AV node and pacemaker. But I brought them in, I brought her back, and then we did rhythmia mapping with Orion. That will go down to 0.01 millivolts. And this is what we saw that they did not see. Right, because their conclusion after mapping, with large area modification was that, maybe you can say these are epicardial, but regardless, they did not see this. They just saw a nice modified roof, and they thought everything was coming from the posterior wall, but really it was coming through a tiny channel in the very roof, and single shot within 5 seconds terminated this. So it can be left with very, very dead looking tissue. So we have to be very careful about modifying to make sure that it's a nice transmural lesion. As you know, the atypical flutter is much harder to control than AFib sometimes. And symptomatically, patient will say, gosh, I got ablation done and I feel worse, right? Because now the heart rate is much harder to control. Next. So, if we look at how this should be, how cryoballoon should be done, we want to first focus on getting that four-vein isolation done perfectly. And from the onset, when we started teaching cryoballoon, almost 15, 20 years ago, we say inflate, ablate, isolate. You got to get occlusion, right? No occlusion, no ablation, and that's really wrong, because you can't get occlusion on every one of these. So half of the time you can get occlusion, you can guide how you do. And what do you do about the other half? You can only track so many of these endpoints to try to make it as good as you can. So the more repeat ablation we do for ourselves, the more we realize that we have to be able to do segmental isolation very well. You have to have a good way to track where the best contact is and get that wide area circumferential lesion as best as we can. Let's see, next. So variable anatomy, and I actually don't do 3D map very frequently. But if you do, and sometimes people pick and choose, but I'm not sure if that really is necessary, because I don't look, and usually you can segmentally isolate just about anything. Next. So we won't talk too much about codecs. It's one way to display this. To me, I don't think this is any more precise, but this gives you a good view of what the left atrial opened up view look like. And some people looking at this view has a better idea of how to fit the balloon to see why a single shot just doesn't always work. So with the left atrial opened up, you can potentially try to imagine this fitting into this one donut shape at a time, and you can imagine why it doesn't always work. Where it will be touching the best, where it doesn't touch very well. Next. And sometimes, you can clearly see that veins are not round. You won't be engaging every part very well. And of course, pulmonary vein is somewhat compliant as you push forward, but then there are areas that's less compliant and you will not be touching very well. And to add on top of that, when you start ablating, the balloon compliance, the pressure changes and contact changes. So this is somewhat a dynamic process to think about. And suddenly it's not so much as inflate, ablate, isolate. And there's a lot more to think about in terms of how well the balloon is contacting before ablation with just occlusion. Then 5 seconds after ablation, what shifts? And where should you concentrate on pushing the balloon? And how do you do this segmentally? Next. So we can actually think about dividing this area, so to say, all right, if we do point by point, you can kind of trace it through with RF catheter. And if you're very skilled, you can do that well. But I'm sure everybody is all very skilled and believe we can do a perfect isolation every time, right? But that's if you think we can do it with a cryo balloon, of course, then potentially it can replace the point by point. But you just have to do it one big segment at a time. The outcome I find is always great. I have new partners in my program now, and when they do my redos, that's always one thing they say. It's like, gosh, the repeat ablations are hard because the high yield areas are already done. What else do we do? Right. Next. Next. Right. So, not to say that you don't understand visually, it's always easier to understand, right? So when we publish things, we always publish like the things on the top left, right, RSPB location, right? The top left corner. Nice antral modification that's like a donut. How often do you think it looks like that? When we do animal studies, open tissue up, I would say less than half of the time it looks like that. Most of the time, even though we have acute isolation, it will look like what you see on the other view. You see a wedge. So one side fits better. You may have PV isolation. You can see all the way around. But you notice the antral modification are never perfect, right? But why is it that we don't have the donut shape every time? Well, it's simply because the veins are not perfect, round, right? So they're not perfect lesions. But going back to creating lines and not making half-dead tissues, sometimes we're making half-dead tissues around the antrum if we don't do segmental isolation. Next. So if we go to example of what I do now versus in the past, I would say that yes, for most of the time, I will look at time to isolation still as the best physiologic endpoint. So depending on when you heard my lecture, I may say time to isolation that's less than minute plus a minute, half, or a minute is good enough. But if you ask me now, I would say less than 30 seconds would be good enough. Because as we do redo ablation for ourselves, I'll look back and say, what is our time to effect, time to isolation? And to my surprise, some of the veins, even though the time to effect can be very quick, like a minute, as we thought that was good enough, they have recurrences. Sometimes because they're thick, and sometimes just what we see is that they don't engage circumferentially very well. Next. So part of it is the phenomena of this pressure change during these type of ablations. So we don't talk about this very frequently, but I want to show you that if this is a model that University of Minnesota have done in the past from the very first cryo balloon, but look at this is occlusion. You see some folds in the balloon. right? But look at ablation when it starts. It becomes very, very tense. Actually, the engagement is different. If you use intracardiac echo, you will see that. And this is how I learned from the very beginning is that I will have perfect occlusion with no color Doppler leak, but when we start ablating, sometimes they will start to leak. And unless you have ice, how do you detect that? And sometimes you have to see it by what's called what we do for repeat angiogram. That after we start ablating, we actually would do a second injection after 5 seconds before the lumen is completely frozen to see if that engagement really changed. Next. Let's go to the next slide. So what we see doing occlusion does not equal ablation. I think that is a very important message. We can use that to our advantage because we'll see that there are new leaks the engagement will change, but you can see on ice, you can do a second angiogram. And so that becomes very important to make sure that you know that there's no other new leaks that happen after you start ablating. Next slide. So what does we mean by relook angiogram? So of course we have the initial CO and we have the initial venogram. We are happy with that. We can start ablating. So if you ever look at a balloon outside the body and start ablating, it takes about 5 seconds for the balloon to really get a steady state in size. So it won't freeze the entire lumen yet by 5 seconds. So you can still inject contrast there. And that's our relook angiogram. So if you do a little tiny puff, you can see that, how much is where it's leaking. You can make tiny adjustments. But of course, if you already have contrast that's still staying inside, you don't need to relook, right? It's still occluded. But for larger veins, for veins that's tough to occlude, you can start seeing where the leaks are. And if you find that you cannot get that perfect occlusion, just make note of where the leak is because you need to do a segmental isolation on this. Next. So if we have a longer time to effect on one vein, especially the upper veins, they're thicker. And usually where there's a leak is actually the anterior part of the vein. So almost by routine now, when I have left superior pulmonary vein ablation, unless it isolates in 30 seconds, I always do a second ablation with the sheath counterclockwise, pushing the balloon anteriorly, even have a posterior leak, just to get that ridge in the front well ablated for another 3 minutes. Next. Of course, you don't want to do repeated ablation in the same spot, especially on the left superior, that left main bronchi is there. So never do repeated ablations for many reasons in the same spot. All right, next. I won't spend too much time on that. So dosing, we talked about it briefly. The left superior pulmonary vein, the most common reconnection site is anterior. Perhaps it's thicker, perhaps because when we push mechanically, it tends to go superior and posterior. So my time to isolation rule that I use now is now 30 seconds. Is that if within 30 seconds it isolates, likely has a really good wide band of contact around the entire balloon. So a single shot, 3 minutes may do. But if it's greater than 30 seconds, then I will finish it. I will go to the left inferior pulmonary vein. I'll come back and then ablate anteriorly. If it's greater than 60 seconds, I have to know which area that angle is. And the second ablation really has to be a complete opposite angle. And very good, the take-home message here is also, of course, wherever you ablated before, there's no reason to ablate in that position again. You have to make drastic angle changes. So I'm a lot more dramatic in angle differences. If it's clearly pushing toward the roof, I'll clearly push toward the base the next time. The contact has to be different. All right, next. So if you look at modeling of what a tiny gap means, a tiny gap that's even 1 millimeter means you will have no lesion. But the tissue will get coated enough to give you electrical change, so you think you isolate it. So imagine this is the 2D of what you just saw in the animal tissue, right? One side gets ablated, the other side doesn't. Some of them have a tiny rim of scar to have pulmonary vein isolation permanently, but this is why you don't have a good antral modification like good donuts. Next. So when we look at segmental isolation, this is also, you can look at RAO position to see when we can push toward the vein. You can see what angle is what that's at. Then you can actually counterclockwise torque to make sure that the sheath is pushing one way versus the other. And that angle can be very dramatic. And on ice, you can see the posterior have large leaks and make sure the anterior is engaged well. Next. So left superior pulmonary vein is mostly like this. And so let's talk about left inferior pulmonary vein. Left inferior vein, smaller, and often the leak is inferior. And this is where it's actually very easy. You just ablate once superiorly, ablate once inferiorly, right? So usually a segmental isolation is needed like this on the left inferior. And usually if I have to ablate to touch up one area, I'll just do 2 minutes because the lower vein is thinner areas and touch up with 2 minutes, especially inferior vein is often in front of the esophagus. That's why I don't want to over ablate in that area. Next. I know a lot of people try to do pull down techniques. I think this being looked over. I won't spend much time on this. It's just not a great way to do ablation. Instead of doing pull down, you want to do separate segmental lesions. Just imagine the second ablation is the same angle as where you would have pulled it down, and to have that perfect balloon tissue contact for the second lesion. Next. So this is what we cover in like the best practice 2. If you remap the antrum, you'll find that this is a much nicer wet area circumferential lesion, even if you do a non-occlusive segmental isolation. And this is a good way to finish your left inferior pulmonary vein. So if your left inferior pulmonary vein doesn't isolate very quickly, I would do a segmental isolation here to finish the inferior portion. Just let this upper part leak. Where you have contact, you have a nice lesion that's expanded. Next. We can go ahead and go next. This just shows different angles to left inferior pulmonary vein. Next slide. So temperature, I won't spend too much on because often people will say left inferior pulmonary vein, I'm just doing segmental. The temperature is minus 30. I'm not doing real ablation. That is not true. That's the mixed return gas temperature. So when the temperature is not warm enough or not cold enough, that just means that, yes, where you touch, you have a good freeze, but where you have no touch, you have warming of the refrigerant, and that return gas is what's making the temperature to be, the return gas temperature to be warmer. But that area that's in contact will still have a nice lesion. Next. So atrioesophageal fistula, nobody wants to think about it, but we have to think about it. But this is very easy to avoid, right? You look at every case that has been done with cryoballoon, we know why. So why is that? Next. So next slide. So most often it's in front of the left inferior pulmonary vein, so if you look at this graph, this is exactly why. Now, it may be intuitive, but if you look at over time on the x-axis and the change in temperature, so this is at the end of the first ablation, at the time 0. The red graph is how quickly the balloon will thaw. The blue line is one of the temperature sensors on the esophagus. If we stop freezing and the temperature is right below 20 degrees, it takes about now up to 7 minutes for the esophagus to rewarm. So if we look at all the ablation we track, now we say a circa, the multi-pole esophageal temperature monitor, and about a third of the time you'll have decrease in esophageal temperature. And a very significant decrease, if we define it as less than 15 degrees, and can be as short as 120 seconds if you're right in front of it. And there's a thermal latency, which we say, yeah, this is something that we'll see a slowing of the very slow rewarm of the esophagus, and it will continue to freeze. And so what this means is that after the first freeze, we should not be doing an immediate second freeze. And that's what will get the esophagus to continue to freeze and cause atrioesophageal fistula setup. All right, let's move along and keep on going. I think because of time, we will continue to speed up a little bit. We'll keep on going. And so proximal seal, we won't talk too much about. It just means that we want to get a best enteral modification as we can. Let's keep on going. Next slide. And we'll move along. So RSPV, I think we need to spend time here on segmental isolation. Now, this is a very common repeat ablation observation. It's a right superior pulmonary vein, right in the anterior part, just corollary to mirror image to left superior pulmonary vein. I will almost do a second ablation with the sheath clock torque to push the balloon anteriorly to finish the anterior portion. Because the initial, if you imagine your balloon pushing from the septum toward the right superior vein, this will be pushing and ablating best in the posterior and roof frequently. But the anterior part may not get as good of a freeze. So this is what we frequently see when we map with, say, arrhythmia or high density mapping, that we see a continuous electrogram as a perfect setup for micro reentrant or atrial tachycardias. So next, and we'll keep on going. We'll keep on going. So segmental isolation, I think, is important. Usually, we used to think this is one of the redos. If we look at just the right superior and right inferior, we have a right middle we did not do before. And sometimes they will have acute isolation. We think is enough. But usually that means that it will reconnect. So often we'll have to do another lesion right in middle and to make sure that it covers well. Next. And we can see how strange anatomy can be. But if you just take time to look at every angle we need to engage, we can get a nice enteral modification. Next. Then we can get a nice enteral modification like this to make sure that the wide area circumferential ablation is really truly achieved. Next. All right, so let's go to next. We'll go to a summary and talk about this. So contact, of course, is the most important part. Anytime we have greater than 2 minutes of contact in typical atria, we have a nice transmural lesion. Angulation, over years, I have learned to be a lot more aggressive with the different angles that to push the balloon to get that contact all the way superiorly, all the way inferiorly, all the way posteriorly and anteriorly to get that. All right, let's go next to have to look for the gap, I think is the most important. So I'll end there. We will have time to discuss and answer questions. Thank you very much.
Thank you very much, Dr. Wilbur Su. That was very nice. I'm sorry you have to rush a few slides, but I think those were the kind of tips and tricks that are very relevant to all of us in these parts of the world. So may I now introduce the panelists. We have two. One is Dr. Sunu from Jakarta. He's working in both Harapan Kita and Heartology. And also Dr. Kelvin Wong, who is in Singapore. currently at the Orchard Heart Specialist in Singapore. We also have in Hong Kong, Dr. Chan Ching Pang from the Prince of Wales, and he will be monitoring the Q&A from the audience. Okay, so without much ado, so let's start the discussion. So mainly, I think Dr. Su was discussing on the tips and tricks and the techniques of pulmonary vein isolation, and I appreciate the fact that this was not something that I heard many years ago, that you're now focusing on segmental, and I agree with you. And when we do point-by-point ablation with 3D map, the points that you mentioned, the ridge has always been a problematic area, and also the anterior part of the right superior pulmonary vein. And I appreciate that now, not just getting isolation, time to TTIs. Of course, TTI is still very important, but to try and make sure that we focus on all those problematic areas. So, guys, any comments, any questions from our panelists? Gary, do you have any questions from the floor first?
Yeah, thank you very much. First of all, thank you, Dr. Su, for your excellent presentation. So it's always nice to hear about your story. We got one question from the audience. So I think this is a pretty common question. So far, we thought, when we do the cryo balloon for the PV isolation, most of the time it's quite distal, the lesion. So the question is about, how much do you pull back on the balloon, and how can you know we can achieve a better antral isolation?
Yeah. So I think part of it is by feel of when you see a nice leak and release from the engagement. So what I look at is that you have an initial venogram. If the venogram is nice, often the knee-jerk reflex is say, oh, ablate because I have a nice occlusion. Now, of course, if this is an example of a right superior pulmonary vein, you're deep in the vein, that's a perfect way to take out the phrenic nerve. So usually if I have a nice occlusion, my first response is not to ablate. It's actually slowly release the pressure and start pulling back until I see it leak. Now, you may be nervous that I would not achieve the occlusion again, but that's not true. It's the same engagement. So when I say pull back, a lot of people will try to pull back forcefully and lose the position. It's really just releasing the pressure and slowly allow that to come back. And once you start seeing leak, you know that's the axis or the direction to get occlusion. So to get as antral as possible, before I push forward again, I will start ablating first. And of course, when you start ablating, the first 5 seconds, 10 seconds, nothing much will freeze. It will just increase in pressure. But that's when it becomes non-compliant. Then I start pushing forward until I engage it well. As I engage, that's when I do the venogram. And then you'll see the enlarged balloon that's not compliant, engage the vein, and then occlude. So that's kind of in slow motion of what I most likely do now to get the most antral engagement. So the days of if you're some of the users, if you try the first gen balloon, we always said, okay, the freezing part is in the equator, shove it in as hard as you can, push and push harder. And that's what we taught before. And everybody got used to that. Everybody wants a nice occlusion. Everybody wants that slam dunk. Oh my gosh, it's minus 60 degrees is great. I focus on the antral modification a lot more for that reason.
Great, very much. So that's just another one question from the audience. Actually, it's a very interesting question. So for Dr. Su, will you routinely use the 3D mapping, or just like what you mentioned, use the codec system, or you use it routinely for the persistent AFib?
Yeah, so I do use 3D mapping routinely to reduce fluoro. And so if I combine ice and 3D, I can get away with less than 10 seconds of fluoro the whole case sometimes. And really just use fluoro as a secondary thing to check. Nobody wants more fluoro. Of course, cost is a concern. So when I use the 3D map, I would say I use it different ways. If I truly have a complex, persistent, and beyond patient, yes, my 3D mapping will include a high density mapping to see what the substrate look like, to see what else I need to do. And cryoballoon PVI and the enlargement of the antrum is just the first half of the procedure. And 3D mapping really plays a role. So in addition to reducing fluoro, if I really use 3D map is when I'll have to get the high density mapping out. But I understand cost is an issue. But when this a persistent one-time success rate is needed, often that is what needs to be done.
Thank you. So just another one question. I think we combine these two questions into a single question. I think probably they mean the same thing. So for segmental PV isolation, will you consider any TTI for this kind of ablation? And if I understand it correctly, I think probably when you do the segmental PVI, will you use a cryo as a first approach, or you will change to the RF? I think probably that's what it means.
Yeah. So the segmental we're using cryo is typically what I'll use. It will be very rare I have to pull out RF to do PVI. And so I will use cryo to get the antrum done. And do I look at time to isolation? Yes, in a way. So for example, if I have a occlusion that's more difficult, I have an inferior leak when the patient take a breath in, I know the inferior contact is not good. So I will actually shift the balloon toward superior and just let the inferior leak a little bit. You can see that on intracardiac echo. I will do the first lesion and you'll see the pulmonary vein conduction delay. Of course, you're not going to see the isolation, but that's okay. You'll see that delay. I pull that down, let the top leak and the bottom is completely covered. Now do the second lesion. Then you see the time to isolation on the second one within 15, 20 seconds. Right. So in a way, that's nice to see always to say, okay, it worked out exactly how I played it. Is that I want a superior, then the inferior. And so that's always nice to see it that way. RF, I do. You made the one comment, Dr. Omar, earlier that yes. So all in all, I use a lot more RF and everything else than cryo. But cryo is such a great tool that I think we basically combine everything that we see to just make the safest and fastest lesion for the patient. So it's not unusual for me to do four-way isolation and then take out an RF catheter to do other things that's necessary, where I think RF can be done. The most common combination may be to take out a non-irrigated RF to do a right-sided flutter line. I did that for 2 cases today. And it's cheap to do. It's non-irrigated, 8 millimeter large curve, so it's not a big deal for cost. And it based on the cost structure, reimbursement structure, of course. But in US, the billing for AFib is separate from the SVT. So if I have a flutter to go after, it's well worthwhile reimbursement-wise to do that in the same case.
Thank you. So thank you, Dr. Chan. Maybe we can get our panelists now to have some say. Any comments, Dr. Sunu and Dr. Kelvin Wong?
Yes. May I?
Yes.
Thank you, Dr. Razali, and thank you, Dr. Su, for your comprehensive lecture. I agree with Dr. Razali that I initially also thought that for cryoablations, the occlusion is one of the most important target to achieve. But you explained extensively regarding the segmental. My comment about this is, what is the kind of maximum dose that we could do with this segmental? Because that this cryo is very, can make a necrosis in a large area compared to the point by point RFA. This is the first thing. Then secondly, regarding the precision F, and you did the posterior wall cryoablations. Could you again explain how to do this posterior wall with the cryo balloon? Thank you.
Sure. So the tissue characterization is actually a very important one in dosing. So if you do a RF ablation, that actually is a concern, right? You have tissue edema and you ablate too much. You think that the architecture of the tissue is affected quite a bit. But versus radio frequency, the cryo is actually very tissue preserving. If you do an acute lesion and do a 3-minute freeze, you thaw it out, you take a look acutely into animals, you cannot tell. It looks like nothing happened. You actually need some time for the tissue to die off to be replaced by fibrosis. So the tissue integrity actually is pretty well preserved in an acute lesion. So how long and how many times can you freeze and how much can you overlap? It actually is dependent on collateral damage. So if I'm, say, ablating the posterior wall, my main concern is not the tissue or how much I'm overlapping. It's actually it's actually the say esophagus, right? So if I know where the esophagus is, I don't want to be doing repeated ablation right in front of the esophagus because that will take a long time to warm. So I will go somewhere else and I'll come back and continue the lesion. So really the main collateral injury areas will be esophagus, right, for the posterior walls and near some of the veins. The left main bronchi for left superior vein in the roof. If you go near the appendage, it will be left-sided phrenic or the RSPV right-sided phrenic. Beyond that, you really can't hurt a whole lot. If you ablate too much in the antrum, you can get the lung, right? Lung wraps around the PV on the outside. So if you ablate very deeply, you'll have dry cough in some patients because of the just lung injury there. The second question is on how do you do a posterior wall? So the posterior wall sometimes it's easier to demonstrate than to talk about, but it's actually very easy when you think about just mechanically what to do. If you were to engage your left superior pulmonary vein, for example, and you push the achieve in to act as an anchor because the vein is already isolated, you're not looking for time to isolation. You can actually clockwise put some bend on the sheath, clockwise torque the sheath, just so it falls outside of the vein and push posteriorly. And you can use the achieve to try to prop it out a little bit and just start anchoring. So you do this in LAL view. You can track using spine as reference how you can actually do the first lesion and then take another half balloon length, push it out from the achieve, a little bit more clockwise torque, and actually start moving it across the posterior wall on the roof. So that's how I do the roof line posterior wall. So if I have a flutter that's been trainable in the posterior wall, I do this. You can see the flutter slow down and terminate. It's actually very nice to see because you have a 2 centimeter wide lesion all the way across. But you do the same thing for the inferior vein and push it out. And which is why when I showed that posterior box lesion, you'll see that in the very bottom, there's a triangle you cannot quite get at. It's not as nice as a straight line across, but you'll get most of the posterior wall pretty well doing that. So really it's just pushing and clockwise pushing that large area to the back of the atria. And I'll do a 2-minute lesions because 2 minutes is what I feel is safe for the esophagus.
Thank you.
Sorry, I think just to continue on Dr. Sunu's question. So I understand because I know you use ice, and therefore when we talk about segmental approach, for us in these parts of the world, some of us don't do ice. I think many of us don't do ice because of cost and because of previous experience. Most of us were not trained in ice. So when you do segmental approach and all this, so Dr. Sunu's question was, it's not as easy when you don't have ice, isn't it, Wilbur? Because you think that you have a gap there. You think the gap is inferior, and you go inferior, and yet you still after segmental approach, superior, inferior, posterior, you still have no isolation of the pulmonary veins. So you tend to put more and more lesions. So I think this becomes an issue. So without ice, what is your advice for segmental approach?
Yeah, so without ice, for ice you can see a left-sided vein very well. You can see leaks. But without ice, of course, you can rely on angiogram, or if you do 3D map, you can look at voltage. Where are the voltages? So even for extra pulmonary vein lesions, I will do 3D map and update the voltage map as I go. I'll take you back to how I started doing PVI, because before Achieve came out, it's just a wire. There was no mapping catheter, and we did double transeptal. In the second transeptal, I would have a lasso or a spiral catheter. And so this is the question. I called the Abbott up, St. Jude back then. And I said, can I freeze your lasso catheter, your spiral catheter? Will it become brittle and break off, or can I freeze it? Well, we never tested it. So what I did was, in vitro, I took the spiral catheter and I put it on the cryo balloon. I froze it and I really pull on it to try to see if I can become brittle and break off. I did that many times. So I feel safe. Okay, I'm not gonna. It's actually okay. So because on a 3D map, and there's no electrode on balloon, so I have no idea where the balloon is landing. So I would then take the spiral and look for electrogram area I want to take care of. Then anatomically on fluoro, I take the balloon to the spiral that freeze right on there. And I see everything just, on 3D map, if you do inside, you freeze, you'll see it fall off the screen because impedance changes. Then you can inflate that area for 2-3 minutes and everything will be dead. Then I use that lasso to actually guide where I need to land the balloon. So that's how I started learning how balloon can take up one large area at a time. And so posterior wall, sometimes 4 or 5 lesions, the posterior wall is done. And so then I started realizing that, okay, this large area modification really can be nice as long as we don't overdo it. So the posterior wall, when we look at the segmental isolation, I'll say it's voltage guided for 3D maps. I think that's very nice. Ice catheter will guide when you have nice color flow, but I actually don't rely a whole lot on ice. So I would say the voltage map carries quite a bit, or even by fluoroscopy, I can hunt around with my Chief catheter until I see electrogram. And now visually, you can even shadow that on your fluoro system. Cindy saved that. And now advance the balloon to where that was and now create a lesion. So that's one way to guide it, poor man's 3D map, to get all the voltage out of the way.
Thank you. Calvin?
Yeah, thank you, Dr. Su, for the great talk. And I think with everything, we've moved on. I remember the time when we did cryo in the first generation, we had 2 5-minute freezers for each vein. We didn't know what to do in between the freezers. But now, we are 180. Sometimes they say even shorter if you want to try. But I think the great thing is we moved on from osteo ablation, from RF to circumferential ablation. And equally, now we have moved on, I think, in cryo from osteo, as distal and as hard as you can push. I think the thing that puts us away initially was how we realized how hard we have to push the balloon to get a good occlusion. But I think you've very nicely demonstrated that actually proximal seal, pulling back, I think it's still counterintuitive to pull back when you get a good occlusion. But I think that's what we need to achieve. But I think without 3D, I think it's going to be difficult to try and assess and do segmental properly. And the other issue is, is the contact. How do you assess the contact against the back wall, against the tissue that you're trying to get? And that's, to me, I think, is the difficult bit. How much contact, how hard to push, and are we displacing it towards the esophagus? That's, I don't know what opinion you have about this.
Yeah. So the contact area is large because it's a balloon, and because it's a large area, you can push very hard. And so from what I see on ice and what we see on animal studies, very good pressure is always needed. In fact, to kind of play it in slow motion, because you push too hard, you will displace it. So usually you have adequate amount of pressure so the balloon stay in place. I'll start freezing. In about 30 to 45 seconds, the balloon is frozen in some good areas. By then, actually, I would push the entire system even more. And yes, you'll be pushing toward the esophagus or anywhere you don't want to cause collateral damage. But because it's a contact dependent energy transfer and is conductive energy transfer, there's no resistive heating, right? So it's very predictable. About 2 minutes is very difficult to injure the esophagus. Even if you're right next to it, you'll get to maybe 15 degrees. And that's very scary when you think about it. But remember, you need to get to around minus 30, 40 degrees to get a real tissue injury for a good 20, 30 seconds. So with all the esophageal temperature monitoring we have done in the posterior wall, as long as you're not doing repeated freezes, you're not doing long freezes, you're actually very safe. So I would say because it's a large area, you can actually push fairly well. Other prototype balloons without the tip, for example, in the past, you can actually push very hard and it will get a very nice large 2-3 centimeter lesions at once. And those days may be in the future to be able to do that with the balloon design that's more designed for it. But when you first start, it's always uneasy to push where you don't typically push before. But remember, as long as the tip is protected, right, you have to achieve in the vein. What you're touching, it's a large area. It's actually very hard to cause harm with that.
Right, thank you very much. So I think we have to move on. I wish we can have more and more discussion. I'm sure all of you have got a lot more comments and questions to ask. I think we can ask further questions during the video. So
Sure.
So we'll go now straight to the virtual case observation and discussion. And Dr. Su will be giving a live, not live, but he will do a voiceover during this procedure. So this video is silent, Dr. Su, so you have to.
Okay. So this is the case of crab balloon, of course, and I think what we see here is that for the same day discharge, we use single growing axis. We always use ultrasound guided axis for vein venous axis, and so 3 venous puncture on the right side of the groin. For one for ice, one for duodecapolar catheter, and then one for 14 short sheath that will be changed for the cryo balloon flex gas sheath. We can probably skip forward to even transeptal. I think it's okay to play some of the some of the areas where we started freezing probably. So I think the main point for this case is probably as we thought about a segmental isolation approach for more difficult anatomy. And sometimes when we look at ice, like right there, I can tell right away, this is a normal sized atria, which people may think the normal sized atria is easy to do, but it's actually harder to do because you don't have much room. So a larger atria actually has a lot more angles to maneuver. It actually makes a balloon type of procedure easier. So let's go. So transeptal wise, I'm not sure what everybody's practice is. Typically I will go for a low end anterior approach. If I have a nice inferior limbus to go through, I will go through that even. And I think in this case, looks like the dilator is even the acutest dilator, which is replacing the cryo balloon dilator that it came with. So this is a all-in-one, quote-unquote, all-in-one wire plus needle that comes out with a push button. You can radio frequency across as well. And as soon as you go across with the needle, a wire can come out to select the vein. As well as just tracking over. So this essentially will replace exchange over wire. So you can see that on the intracardiac echo, the tenting spot is the top of the inferior limbus. And usually on eyes, you like to see the mitral valve as well to show how anterior you are. And that will be more important in a normal sized atria too.
I don't think many of us are familiar with this transeptal set, the acutus.
So this is the so So right now, I'll admit to you that I don't particularly love this dilator because it has a pre-bend on it, and we were just trying it out once. But this actually will allow us to, because I can tell that I'm actually tenting with the flex cath, which means that um, I have this in place. I have this dilator in place because that's FDA now FDA approved. So you can see that the needle goes across and wire goes to follow, and you can actually do this all fluoro free, and you can, and wire can go straight across and it will track right through. So this is a dilator with this advantage that you can go directly across with a large sheath and be comfortable with it. Honestly, right now, when nobody else is watching, I just use the long needle to go right across the off label. But it's really your comfort level of what you have. But with ice in place, I think a lot of these are very comfortable to do. Any question about the transeptal process here? Or I'm happy to talk about what else you can see with this, but this is a kind of a combo dilator to replace the FlexCast dilator, especially for this procedure.
Can I just interrupt? Sorry. When you go for pick your spot, do you go at the limbus itself, the thick portion? Do you intentionally go for that, or just the thin portion as anterior and as low as possible?
Typically, I actually go for the thick portion, the muscular portion. So we published this. If you search on online, JOVE, the Journal of Video Experimentation, we actually did a whole video series on doing the transeptal going through the inferior limbus because I think it reduces the iatrogenic ASD. Most people think it's actually difficult to go through, but I have to say I've done thousands of these. It's very easy to do because the thicker portion actually has more muscular. It's not as fibrotic like the fossa. And fossa will tent quite a bit, and you're higher up. Sometimes you're tenting and pushing more horizontally. It becomes harder to do. And if you go through that closer to the intracardiac skeleton, it doesn't deflect as much. And if you have ice to guide it, it goes right through the muscular portion. In a thick sheath, most people think it gets caught, but it catches less likely than you're going through the typical fossa location. So I think it's actually much easier to do and makes a cryo balloon like procedure easier when the lower you are. And so that's kind of how I learned it. Actually, the first time I did it was in a patient with a ASD closure device. So I was trying to find a place to go across. I went through the inferior limbus. To my surprise, that was the easiest case I had ever done up till then. Then I started looking for the lower anterior spot to do it.
But you can get through it with just the Brockenbrough needle?
Yeah, Brockenbrough needle. I actually don't even use Baylis needle. So I know they keep on asking me to use all these different contraptions. All I use is a needle. And in fact, for repeat ablation is even easier because fossa is so done over by everybody else. It's so scarred. It's hard to go across. And nobody goes through the inferior limbus area. So it's actually easier for that reason.
You have to be careful it doesn't slide out of the limbus. And then, so how it possibly is very thin when we are pushing. I mean, the extent must be quite limited.
Yeah, so inferior limbus, of course, some have good stretch of inferior limbus, some do not. So when they have a nice triangle, then that's when I go to the middle of that triangle. If they have very short limbus, and I just go through the fossa itself. And of course, I'm watching as the critical time in transeptal is the tenting. And so during the tenting, I'm very, very careful in looking to see where the tent is. I will scan on ice back and forth until I find the maximal tenting spot. And only when I'm confident do the needle come out. And when the needle comes out, I always look again to make sure I'm in the right place before I push across. So that's my typical practice. At least, knock on wood, we've done ice guided transeptal so frequently we're very comfortable with it. The most important part I think about this now I remember is when I go to Asia, a lot of different practices that we always anticoagulate to therapeutics. I'll give 10, 15,000 heparin before going across. And most of the time, if you don't have ice in Asia, you're not comfortable giving heparin. But as you use more ice, you'll realize that if you don't give heparin before transeptal, you will see thrombus on the sheath. And that's what we end up seeing. And so I think to reduce risk of CNS events, heparinization before transeptal is so critical, because it's always surprising how many times, because I'm teaching ice for many centers in Asia, and sometimes I'll tell this story, and then they'll look on ice and say, "What is that on the end of the sheath?" That's the thrombus. They'll take a large syringe, we'll suck it out, and we'll push it around the gauze and say, "This is what you're not seeing before ice." Because you see that very frequently if you don't anticoagulate fully before going across. That's the most important thing. I just want to say that before I forget.
I think that's a very important point. Most of us do a transeptal with transesophageal echo. And of course, I'm not sure if I take a survey, how many of you give heparin before transeptal? Sunu?
I always do the transeptal first and then heparin.
Right.
But I'm regarding Dr. Su transeptal approach using this catheter. If we don't use ice, is it still possible, or do we have confidence enough to do transeptal without ice?
Yeah, I mean, I can tell you, I am not. Unless I'm very good at recognizing and doing pericardiocentesis, which right. But I think it is very important. But I'm one over time learned that I can deal with bleeding much easier. I can deal with clot. So I learned that yes, now after thousands of transeptal, I can say yes, I will anticoagulate before. But there are different tricks I do when I do case without ice. I will take contrast and stain the septum to see that artificial tenting.
Yeah.
I will not go for the limbus. I will go for the typical fossa.
Right.
Can I just check also, do you think without ice, just with transesophageal echocardiogram, we can visualize the limbus and direct it to the anterior inferior portion of the limbus?
I'm not very experienced with TEE for that. I'm not sure what the rest of the panel's experience are.
I mean, most of us do TEE. We just go for the most easiest point, the thinnest point. So your point about being in the thicker part is a very interesting concept. Most of us try to avoid the thicker part because we assume that it's harder to puncture. Even with a broken bone needle, sometimes you have to use that a bit of. Yeah.
But that's actually the interesting part, because the fossa itself is more fibrotic than the limbus. And everybody who's been in my lab watch me go through limbus always feel like, gosh, that's going to be so hard to do. They see it slide right through. It's like, how is that? That is so thick.
Yeah.
Like it goes right through. So that's but I know it's very hard to imagine, but then it's until you try it, it's then you'll see for yourself what that feels like. But it's because it's muscular. I feel like the iatrogenic ASD is we just don't see it. It just closes up, as you can imagine.
So with the transesophageal echo, it's not going to be easy. I suppose. So can we just now? I see that again, this concept of 3D map. I see that before you do anything, you have already done a quick 3D map with the Insight using the chief catheter. And a lot of us in these parts of the world, unfortunately, do not use cryo with 3D. Some of the lucky ones like Kelvin do, but many of us don't. And we are just, it's either cryo alone or 3D alone.
Sure. So here 3D really is, so while I got transeptal, the balloon inserted, it will take some time for the machine to recognize and warm up and initialize and flush itself to get machine ready. Really is very quick to take the achieve and quickly just map out 4 veins. To me, this is just to reduce the floral use. And here, otherwise, it doesn't help me anything else, any other way. For us, actually, until this year, the 3D map is not currently a separately billable portion. It used to be. Now, here that, going back to the video, I'll say that the left superior actually did not isolate. This is actually a shallow common ostium. So we actually just pushed and make sure that superiorly on ice, we have good engagement. We ablated. We actually saw a delay, but it did not isolate. But I don't worry about it. I say I'm going to the inferior part, and we'll do the inferior next. So overall, when we look at it, the use of 3D, yes, we can map voltage, we can see where things are. I have to say that's really all it does in helping me. Can I, if 3D mapper happen to not show up, I'll do the case without 3D. It's okay. It won't ruin my day. But for a cryo balloon, it really is more of a reduction of fluoroscopy. But if I have to pick one tool to have in addition to cryo balloon, I pick ice because that's the dynamic look. So you can see on ice, I have a leak on the superior side, which is on the right side of the balloon on the ice image. My balloon is outside. So this actually is helpful. This is a second freeze. And we're able to see that temperature is horrible, right? But it's actually freezing the inferior part. And so this is very much a segmental approach to a kind of a common ostium situation. Now, ice is also helpful here to help me see how much of the balloon is in or outside of the ostium, because with a large ostium, of course, like a common os, it's very easy to bury the entire balloon inside. So of course, by freeze, so this is a good example of a very strange temperature curve sometimes, and to say, wow, this is not freezing at all, but it really is. What we're freezing. So when I put the catheter inside, when I put the balloon and start freezing, what I'm looking at is on ice that the left side to the balloon, which is the inferior side is not leaking. So this is what I typically would do to make sure that segmentally I'm focusing on one segment only. I don't care about anything else. I want the inferior side to be done, or I want the superior side to be done, or I want the posterior side to be done.
So practically, when you're dealing with a vein, how many segments do you normally need to freeze? Is it 2 segments, superior, posterior, superior, inferior, or you need to do 4 segments?
Yeah, for a typical vein, like the superior vein, optimally, if I don't see anything else, I don't have mapping, I don't have ice. If I do a superior vein, I do a typical occlusion pushing initially toward the superior, more posterior, which is what we typically naturally push toward. I do the second freeze anterior on the upper vein, then that would be good. For the inferior vein, it's more of ovoid going superior inferior. So if I take one superior, one inferior, if I have no mapping, I have a balloon, I do it blindly, I would say 95% of the time will be a perfect waka type of lesion if I just do that. On the superior vein, I do one freeze, and I do a second freeze anteriorly, and I go to the left inferior, I'll push it toward the carina, do one, I'll pull it down to do another, I'll mirror that on the right side. I'll have most of the time a very nice wide area circumferential lesion.
Sometimes when we do point by point, we notice that even though we have a good wide entrance circumferential ablation, the carina can still be active, and we have to do some lesions in the carina. How do you
Yes.
do the carinas?
Yeah, so actually we'll push the balloon very up, and so that balloon will look like it's going from high to low. So if on the inferior vein, if you have engaged in inferior vein, and if you look on fluoro in the LAO view, you will see that the balloon is pointing straight down.
Right.
And that's one view, one ablation. And the second ablation would have the balloon horizontal or even going from the low to high. And I think that's similar to the photo I showed in like best practice 2 to show that how to touch up the inferior side. Because most of the time people find a good occlusion going from high to low in the inferior vein. But the inferior part really is not touching very well. And often that's where it reconnects. And most of this experience is just doing my own redos. What I thought was good enough. Really, when you do high density redo ablation, it's like, I'm not as good as I thought, right? And so why is that?
Do you reposition the achieve in different branches to achieve segmental? So you can high to low and low to high?
Usually just by placing, and so usually for inferior vein, placing the inferior branch would be the best. I don't need to change it from that. And sometimes for the upper vein, you need to get to a much higher branch to push it to a different direction. But really, that just acts as a fulcrum anyway. So it really is the sheath that changes the angle. So here you see that I'm doing is at a third. I'm trying to position the balloon, and this is the width. So we did one in the lower vein, right, with the to the inferior side. Now I'm probably doing another freeze with the balloon in the middle, and so that's kind of pushing toward the carina area or the middle portion. So I have an upper leak, I may have a lower leak, and that may be what may freeze it. And I think this is also a day that the console was acting up. The second valve is opening late, so we have the initial drop, and the second drop doesn't happen right away. So you see an additional bump that we typically don't see. That's actually not normal, but that's actually a delay in the second valve for this. This console had a lot of mileage.
So the vein is not isolated yet, yeah?
No, I think the inferior vein, I actually didn't pay attention too much about whether or not actually that's far field or near field, but it's probably a near field. And so this is one where we really had to do segmental isolation to see what's going on. And
that's spacing during the cryo?
Yeah, so we can actually pace whether we do pacing to elicit, try to capture. Sometimes we'll try to capture CS distal. If I push the CS distal all the way out, here I'm actually just looking for diaphragm. That's what I'm doing.
Oh,
so
I see.
A parallel process. So while I'm doing the left side, and after I finish the left side, I would then, as I do the left side, I will try to look for diaphragm. So that as the left side is done, I'll go right to the right side.
Right.
Yeah. So here with the segmental isolation, I think we're able to. I think some of those left signal are actually all far field stuff that we're able to prove. So left-sided freeze, we did 3 freezes. The first one I delayed the superior vein. The second one actually was in the lower part, and then the third one was in the middle, and that actually isolated the entire common antrum there. So that was only 3 freezes on the left-sided common vein. And when we went back after so we saw the signal in the left superior, and after we did the left inferior in the middle part, we went back to the left superior, and the signal were all gone. So that was actually good to see. So segmental wise,
the counter clock to get it to the reach. Do you that now that the veins are all isolated, was that part and parcel of the 3 freezes?
This actually wasn't, because the middle part, I would have done that to kind of push toward the anterior part. So in my mind, where the hardest part to isolate and to touch is as I move around. So you can see I'm actually updating the voltage as I go to it. And sometimes I see a nice postural wall modification. anterior, of course, see the far field appendage signal. But to me, that's always the part that I try to reconnect. So usually I will push that balloon very much toward the anterior side to actually try to get that. So this is the voltage map as I update it to say this is what's left over after 3 freezes. So one on the very top, one on the very bottom, and one toward the middle, toward the carina, to get the kind of common antrum out of the way. And on the middle part, I would have probably deflect that more anteriorly. Now here, I could actually do a fourth freeze just on that ridge as well, but I don't think I did that in this case, thinking that it looked good enough.
So, Dr. Su,
yes.
Yeah, previously you just explained that during the LIBV cryo freezing, you also check the diaphragm stimulations. So because in our practice, usually we only check when we did it on the right side of the BV.
Oh, yeah. So I was looking for a diaphragm in anticipation that I want to locate the diaphragm and be ready for the right side of the vein. Oh. So that's because I was bored while I was freezing. So I was parallel processing.
He's a multitasker.
Would you say the more? I'm sorry. Would you say the more aggressive technique of hockey stick and whatever they did in the past is not necessary with this segmental approach?
Yeah. So the hockey stick and the big loop and all that. When the Europeans started talking about it, why they had to do it is because the transeptal is too high. So that's why you had to do that. So with the segmental approach, with the sheath reaching it from the lower part of the septum, it actually becomes a lot easier to do with just the available angle of the sheath.
So, Dr. Su, there's a question from the floor, and I think that's a pretty common question for all of us. So it seems that you are doing the cryoablation, and at the same time you acquire the voltage and also see the electrogram. So even though for eyes you think you are have a good contact with a seal, does it always mean that you have a lesion there, or will you use the voltage map to to verify the lesion? Without the eyes, is it mandatory to use the voltage assessment for this kind of a lesion?
Yeah, so I do gather voltage as kind of an endpoint just to know how wide of an antrum I made in the posterior side. Two things. One is when is wide enough, then I would have, when it's not wide enough, I would extend it, right? Depending on how big the atria is. It's like a visual proportion that we see, right? You see a big 6 centimeter atria. You see antrum is not that very well widened. I would push the balloon posteriorly to widen the wide area circumferential lesion. That's one thing. The second thing is, I never want to. I make fun with my Insight mapper to say, yeah, we're doing low density mapping, and we are. To call that a real map, voltage map with Achieve, I feel bad as a real EP to call that real voltage map, right? What do I use for cutoff? It's hard, right? So we all know that. So because we're visually trying to cut out what's far field on the appendage, and so yes, so posteriorly without far field, it's give me a sense of where things are. But clearly the pre and post would be very different. So I used to track that. So as I gather pre and post, that's why my mapper is. So this is one way for me to gather, have a database of what did I really do in that case. Was that a question of what do I use it really for? Because the voltage itself, it's one of the surrogate, understanding the shortcoming of what Achieve really means. But I'm also too cheap to break out a real HD grid in this case to map. But if I have to, I will. But for PV isolation, it won't make a big difference. I will do pacing in and out if I have any question, right? You can do differential pacing. You can put the CS all the way to the deep, try to pace the appendage. So you can try to sneak the balloon out, leave the chief in, and pass a pacing catheter to the appendage just to pace the appendage out of the way. So when you're starting, you want to make sure that's not the that's not the far field. You can always do that initially to be comfortable with it. So here we are on the right superior pulmonary vein, and of course the balloon ablates anterior hemisphere. So one of the fun things that like we had a visitor today in the lab, and just starting with cryo balloon ablation, the first thing I typically do is put the balloon in the saline, and I'll freeze in saline, and I'll show them the ice cap. Right? So that you see the entire front half of the balloon is covered in ice. I said, imagine that's actually what does the ablation, the entire front half of the balloon. So wherever you push forward, the front half of the balloon will actually freeze anything that's in contact with. So in the right superior vein, I think we're taking it out one by one. The typical routine ablation. I have to admit I didn't see the video beforehand, but I'm trying to remember what this case was about. We recorded a lot of cases for demos, and so just record it as it comes. But I see that the superior is isolated, but I also see that there's a middle vein here. So I talked about in the middle vein, I usually would say, well, if you cover it from the superior and inferior, usually it's good enough because it seems like it covers it well. It's such a big balloon. But the more I see, the more I realize that middle vein, unless you put a third lesion there, the antrum will look like a figure 8. We want a big oval, right? Like wide area, not just a figure 8 with a small waist that may recover and become an isthmus for flutter. So I'm very generous with repeated ablation, different angles. As many different angles you can squeeze in there is what will get that wide area. I'm a big fan of just pushing a way up, pulling a way down, and to get that segmental isolation, the modification of the antrum now.
So, Dr. Yu, actually, there's a question, and I think probably relevant to the segmental ablation. So, when we do the RF, we always know that the tip is the part to deliver the energy. So, for the cryo balloon, we know the lost hemisphere of the balloon should be the site to deliver the most of the cryo energy. But having said that, when we do the ablation, we do the segmental contact, and then we see at the eyes. And how can we sure that that's the part to deliver the energy to the tissue? Because sometimes you cannot get the precise location about the site of the ablation.
Yeah, it is a guesstimate on where you push the balloon. So it depends on where you anchor the balloon. So if I'm anchoring the balloon, say in the left inferior vein, and I'm pushing posteriorly from there, I imagine that a third of the balloon will be in contact in the back with the back wall. And so if you do have a case with 3D map, you can do repeated voltage map after every freeze to get a sense of where did that lesion land. And that's actually how I learned. I talked about double transeptal in the past when we didn't have Achieve. And that was actually the best time. I would put a 20-pole spiral in there. I would just map, and I would put the first spiral there, freeze right on the spiral, and see all the electrode fall off, and see a big, just silent area. Remap, it's like, wow, that's a huge area. And so back in early maybe 2009, 2010, that's what we did, and we did a lot of these large area modifications. And that's when we started trying to write it up, and we did that in a plastic model to show how big of area that can be. And so by doing that one segment at a time, you will see that by pushing the balloon toward the atria, you can imagine the contact area is a big ovoid.
I asked about the temperature monitoring. So are there any circumstances where you actually abort a violation, or what exactly are you looking at with the esophageal temperature?
Yes. So esophageal temperature, my cutoff is 15 degrees. And in general, now there is also a circa monitor that will pick up the locutus part easier. That's a different lecture by itself. In general, esophageal temperature monitor are highly inaccurate, but when it's too cold, it's definitely too cold. Now, I use the esophageal temp monitor as a marker on where the esophagus is, not so much where the temperature shows. I always assume I'm freezing the esophagus. So, for example, in this LAO view, the RSPV freeze, the esophagus is behind the balloon. That will never freeze, right? Not anywhere close to it. Right inferior vein, if I can imagine in this LAL view, this is closer to the right inferior vein than the left inferior vein. So in this case, right inferior vein may actually freeze this. That means that I do not do repeated freezes in a similar spot in the right inferior vein. I will go somewhere else, do a freeze, then I'll come back. Yeah. So here is a large right superior antrum. So I think we're doing kind of somewhat of segmental isolation. Again, the temperature profile here is a little funny looking because of the valve issue more so. But then the valve of the second valve is opening a little bit late. That's why you have a little increase in temperature before decreasing. You also notice that the temperature is not the greatest in terms of how cold it gets. But again, I don't really look at how cold it gets anymore, except if when it gets too cold. If it gets too cold, that tells me that, yeah, I have very good lesion all the way around. I can potentially stop or I may be too deep, right? I may be able to stop the ablation earlier. But when it's not cold enough, no, I look at, okay, well, I'm doing, where am I in best contact with? All right. So here, of course, then we'll start isolating the right superior vein with kind of a segmental. I probably push it more anterior as well to make sure that the right superior is well done. And then I may work my way down to the right middle, then the right inferior. But here, clearly, I'm really focused on every different angle I can push toward this antrum, even if as complicated it can be. And I have no idea walking into this case, that's what I'm dealing with. So really, it's just as I do this, and I'll see. Now you can, of course, do a venogram right from the onset. You can see it.
Do you do pre-op CT to look at the pulmonary veins?
Only if they have prior RF ablation. So I can say that I didn't cause the PV stenosis. But I actually don't. Now I do MRI more routinely because we're doing studies for tissue characterization. That's not working very well either. All the MRI studies, I'm not sure if you guys have more experience on MRIs, but I'm a little disappointed in what all the different software can do.
Dr. Su, if we don't use the eyes and we want to do the segmental approach, can we use the signal of the spiral catheter to guide which segment we need to ablate more, like number 1 or number 10, something like that?
Yeah, so even without 3D mapping, because remember 3D mapping is just what it summarizes for us visually. But even with just on fluoro, in cases where I don't have 3D mapping, I'll just put the spiral right on the antrum. I'll just look to see on fluoro, count out where the electrode number is and where the voltages are, and so that's then I know where that needs to be. And so if I don't isolate this vein on the second freeze, I will pull it back to the antrum and I will map voltage, or I just look visually to say, okay, electrode 2, 3, where is that? Okay, that's anterior. So, okay, I got to go anteriorly, right?
Yeah, thank you. That's important for us to guide.
Yeah. Poor man's 3D maps. That's what I have always done in the past, but now but I wonder whether we have to cut back on 3D mapping, because for the first time this year, for AFib ablation reimbursement, they took away 3D mapping.
No,
It's combined now.
No,
actually, regarding the trial of the cryo versus RFA, for the cryo arm, did they use 3D also?
For fire and ice,
Yeah,
fire
yeah.
and ice was mostly European, so no, they actually did not. They were actually just floral based.
I see. Okay. So with the additional 3D, the outcome might be better. Yeah, should be better now. Yeah.
I think so. Well, I think outcome could be better in few ways. One is the procedure for floral will be a lot less. So usually if we're not demoing, I mentioned that most of the time our floral time will not exceed 1 minute, and for the whole case, if we are 3D and ice. And typical PVI, if it's pretty smooth, I hardly use 10 seconds of fluoro.
But you don't take the venogram normally.
Oh, I will do the whole case without venogram because I would even just use color Doppler. So if someone has renal insufficiency patients, and I will not use contrast.
So Dr. Su, again, the same question. Last time when you came to Hong Kong, we did the iSky cryoablation. I will still remember the comment from you. And is there any change for your choice? And actually, for both the Akinef and also the Arbor eyes, remember that actually one of them are very difficult to visualize, the Doppler. So do you find any solution or any change, or is still the status quo?
Yeah, so color Doppler for the right-sided veins are sometimes difficult. And to really do that, you have to get into the outflow tract, look back. And for the right superior vein, that's the most difficult one. If the other thing you can do is use saline injection, because saline injection, if you have a leak, you'll see bubbles on the left atria. The other thing you can do is actually do pressure transduce the tip, so that you can see occlusive pressure as you occlude the vein. But often that can also mean they are too deep. So these are all considerations, of course, and with the caveats that yes, it can show you one thing, it can show you occlusion, but it won't show you if you're too deep. So you have to use contrast, and you have to use ice to see the back end of the balloon, or you have to be able to see you have to see on the ice, the back end of the balloon, to make sure you're not too deep. So here, in the case, we did the right superior vein. We kind of did the right middle part, and one freeze in the right middle. It really just to finish off the antrum to make that as wide as it can. Then we're in the right inferior now, and so right inferior. Right off the bat, I know this is going to be painful because it's tiny. Tiny right inferior typically means that it's not going to have a nice antrum for you to have a wide area of contact. So right away, often for tiny inferiors, we often, even though you push it hard, you can get isolation. To get the antrum modification, you still often want to have a segmental approach. So on ice, you can really, or on floor, you can really pull that down to get that contact all the way in the inferior side. If you shoot contrast, to make sure it will leak superiorly, and that's okay if I just want to target the inferior side, to make sure that inferior has a nice contact and let it leak superiorly. I wouldn't care. So of course, here the idea is to be able to get something that's closer to a wide area circumferential lesion. So if you can imagine, if I just do one shot in the veins, I isolate the veins, but the antrum won't look that nice. So I think more complex anatomy to get the segmental isolation, usually that's what's necessary. And this part, heart being more of a normal size atria, is also something that makes it more challenging because you don't have as much room to maneuver.
How aggressive do you challenge, after the isolation with isoprel, and what sort of dose do you use, or you use adenosine?
And I used to do that until they decided to make it $3,000 in US. So that's how much the isopril and adenosine per case now is if we use it. So I actually are not very aggressive with that now, mostly because too that adenosine, if you have good time to isolation, adenosine doesn't help. It very rare does that show anything for crowd cases. Isopril I never found to be that helpful. So I actually don't routinely use it now. In the past, we do it very frequently. If you're in private practice, you do it because that's a separate billable item as well. But now that these are all very expensive drugs, so we actually shy away from using it unless they truly have value.
How do you look for non-PV triggers?
So if I suspect I had non-PV triggers, I would run induction with burst pacing. And if it's a typical paroxysmal AFib, I would not be aggressive in looking at anything else. I get the 4-vent isolation done, and I may do some burst pacing throughout. If nothing else is mappable arrhythmia, then I am essentially done. What I do, the endpoint does vary depending also on where the patient comes from. I hate to say it, but they do. If they're from out of town, I'm a more aggressive inducing. I may use adenosine, isopril in those cases. If they're from within town, I can get them right back to the lab. I'm not as aggressive with it.
But you always try to induce after the whole procedure finish, yeah, the AF.
Do I always induce?
Yeah.
Yeah, because part of it is the training my staff and to do inductions too. So here I'm not sure if we actually did it, but then sometimes in filming cases I don't have the staff run through the routines that we do. So sometimes when we freeze, we have nothing better to do. Then I start asking the staff to do everything, including inductions, pacing different areas, and just make sure that we're done. Here, I think the inside rep is showing some of the pre and post voltages, and not the high density map you like to see. Nothing publishable, but visually you can tell what's what. So that at least we know that at least posteriorly we can see a kind of a wide area circumferential lesion there.
Yeah.
Yeah. So here, of course, in the inferior vein become very difficult too. So we actually had to look at pushing that more toward the septum and sometimes more toward the posterior side. And sometimes with small veins like that, you can think about it. It's like a top pivoting toward an anchor point, and where it wants to really anchor is really dependent on where you want to push. So sometimes looking at LAO view and really pushing that posteriorly, sometimes toward the away from the septum, sometimes to the septum, is also very important. So if you get frustrated isolating, even blindly, you can go from different areas, just push to a different angle, and sometimes off axis, and sometimes pulling the achieve to the antrum to say, okay, where is that voltage? If it's more toward the posterior side, then go ahead and clock the counterclock the sheath and push the balloon off axis to the posterior side to make all that area go away. So it can be very much quote unquote the mapping guided at the antrum just to see where the voltage is to push toward whichever area. So that definitely can be one way to do it without the visual 3D map.
Dr. Su, so for the right inferior, there's no need to do frantic pacing?
We do. It should. If we forget, that's because we forgot.
Because I see that you're not pacing at the moment.
Yeah. Also, this actually is probably because I'm pushing toward the posterior. So this is where I actually said that, okay, that the posterior side toward the posterior wall is where that is, and so that's really away from the phrenic course. Right. So I actually counterclockwise the sheet, push it off axis right to that posterior wall side to get that posterior wall done. So that's probably why I didn't pace in this. I think I remember this case for doing that. It's like, yeah, you don't need to pace because that. And also sometimes I will hold pacing for a while too, just to make sure that the area that I want to contact freezes. So usually for the right inferior, I will not start pacing phrenic until 30 seconds into it. Now, I have to admit, as many cryoablation as we have done, sometimes we do forget.
and you go for the right superior first before the right inferior, isn't it?
I go for whichever one it falls into first.
Yeah. Okay. I agree. I mean, there's always this teaching you should go for right inferior and then go right superior, but I always go from the left to the right superior. It just falls in the right superior and just freeze it there.
Exactly. There's no need to waste more time trying to get the sequence right.
Right.
As long as we're watching and being careful, I don't think there's a big deal. Yeah, so I push toward the posterior part of it, I think, and try to figure out where the voltages are to try to clean up the antrum. So sometimes as I post ablation, I will go back. I think we're updating the voltage. You can see that as we go through where we have prior voltage, we're updating, and the antrum basically got widened.
Yeah. Do you do this again after 30 minutes?
I don't wait for 30 minutes anymore because usually I don't see it changing very much unless I truly find that to have very poor time to isolation, have to really do segmental. Then I would then come back and then do another remap just to make sure that nothing else changed.
Right. So once this is done, that's it. The case is done. You don't.
Correct. Yeah.
Right.
So I think here you can see that we're just updating the voltage as if we have high density map, but no, we have low density map. But this gives the idea of, okay, where did I actually make the lesions? Is it good enough, even with a wide antenna mapping?
So, Dr. Su, a quick question from the audience. So, do you commonly see the pericarditis after the cryoablation, especially after extensive segmental ablation? The second thing is sometimes when you have a contact of a chief catheter with a cryo balloon, do you think that it will affect the contact and also the lesion size for that particular case?
So if the chief is in the way of the cryo balloon, I don't think it will affect much at all. Of course, every material have heat content. You will affect to some degree, but the cryo energy is so powerful, it will freeze right through and cause a huge ice block. So it's a very minimal amount of blockage of ice or freezing. What's the second part of the question?
The second question is it commonly see the pericarditis after the multiple segmental ablation?
Actually, that's very rare. So of course, it's very common for us to, when I do RF ablation, I always give NSAIDs. Cryo balloon, I don't necessarily do that, and it just there's a lot less inflammatory response right off the bat, and so I think that of course the healing response, the inflammatory response is different with freezing versus the burning. So I do find that it's much less so. Yeah, usually for RF ablation, I would give 3 days of NSAIDs. For cryo, I just don't have that routine. Yeah, most people have done very well with it. So I think as we updated the voltage, just throughout, especially with complex anatomy, different branches branching, we like to be able to see that we did actually do a wide area circumferential lesion. And unless we do multiple segmentals in this case, there is no way for us to achieve a good, wide area circumferential lesion in this case.
As we mentioned, Dr. Su, many of us do not have the luxury of combining 3D and cryo, but I think what you have shown us, even without 3D, movement of the achieve, not just put it in one spot and thinking that you have isolated a vein is enough. But I think we should be able to, even without 3D, move the achieve all over the veins, anterior, posterior, go to different segments to make sure that we don't miss a spot. Do you paste inside the vein?
The achieve or the balloon?
The achieve, yeah.
Achieve, yes, inside the, but I don't ablate. It's a question to ablate inside the vein.
No, I mean, once you have done the isolation, do you test for exit block?
Oh yes. So often I will pace around, and but often it's very rare if I get entrance block like we do with no voltage. You have exit block, but it's always fun as we freeze. Often we'll pace the achieve to have local capture. You can see exit block acutely, right. And the hard part, of course, is that you pace the achieve. Sometimes you capture the appendage, but I think in this case, I think if you look at the voltage map, to just see the voltage map itself, and sometimes we're not sure we will pace because you will see far fields.
Yes.
And so I will pace around where I see far fields to make sure that's not a near field. So I think to get a wide area circumferential lesion like this, you have to be able to do multiple angles. Cryo balloon otherwise is not designed to do a single shot. To do a wide area like this, right? If we have the choice and use the skill to do a focal point by point, this is the line we would draw. And so we like to be able to draw the same line with cryo balloon, and this is the only way to do it is with segmental approach. So the more cryo balloon I've done, and to kind of see the redo, the more segmentals I do for this reason.
I'm not sure whether how many people are actually doing like what you do, because I think it has to be, it looks like we have to reset our mind, because when we were first taught to do cryo balloon, it's just like you get a good seal, you get TTI, you're done. And, and then you go back after 30 minutes, check, just put the achieve in one spot, no signals, try to do pacing and you're done. But as you mentioned, then I find that there are recurrences, and then when I map with 3D in a redo case, I find all these spots that I miss, and I just wonder whether was I careful enough. But what you show, I think we need to, all of us who do cryo, need to change our mindset and try to approach the cryo like we do for point by point, and achieve a more segmental approach to get more wide antrum isolation. And for me personally, Dr. Su, I move away from cryo because I was not able to get both cryo and 3D, and 90% of my ablation now are with point by point. So because I feel that I can direct the lesions where I want to and not get the balloon to tell me where to go, because the concept was just go deep, make sure there is proximal seal technique, and just go. So therefore, I feel that the balloon is dictating where I should be ablating rather than I dictate where I should go. But you have demonstrated that you can dictate the balloon where to go, rather than the other way around. So I think it's a mind shift, it's a paradigm shift that all of us have to bear in mind. And I'm glad that we have this webinar. I hope that many people who are watching this will be able to now get this sort of a new approach to how we do cryo balloon ablation, and we can still achieve the kind of wide antrum circumferential ablation that we achieve with point by point ablation.
Right. I think that, as you mentioned, the more redos I do for myself, trying to see how do we create a perfect lesion in the heart, the more I realize that that's what I have to do with cryo balloon to compensate for that. I think not necessarily I learn more from doing 3D at the same time to guide it, but I think we mentioned that just the ability to be able to see that we get different angle, different shifts, be aggressive with the different angles, you will be able to see the wide area circumferential lesion that's more like what you would do with a perfect focal that you would draw.
Yes.
I think just to wrap up the case, too, I'm not sure how many of you do figure eights with three ways with stopcock. That's what we do. Typically, we would pull right in and be able to just get that figure eight to be able to close off the venous, and 3 hours bed rest, and patient will walk around. If it looks good, and they will go home the same day.
So yeah, I mean, I do it the same way with the stopcock. I stopped using the sutures, or sometimes sutures just doesn't work. But you mentioned at the end of 3 hours, you would then release the pressure.
Yes. So we reverse with protamine typically.
Yes.
And so this with this way, then the patient can move off the lab and go to the recovery area. So we can start with the next case.
Right.
And yeah, so this is a good way to just get that process going.
How many times do you have rebleeds and you have to push back the stopcock and the patient can't go home the next day on the same day?
Yeah, so for one of the criteria is that if you have normal venous pressure, so heart failure patients, liver patients, coagulopathic patients, we're more careful with it. We'll watch them overnight and remove the figure eight or next morning. Or even sometimes they want to go home, I would discharge them with the three-way stopcock in place, and they'll come back to clinic the next day to get removed by our nurse. And
what about anticoagulant? Do you stop or you don't stop?
We don't stop. The higher risk patient, we don't stop. Chest VASC of 2 or less, if they're on anticoagulation, we may stop the morning dose.
Right.
But essentially, we don't like to stop anticoagulants. So one thing I do say is, I'll deal with bleeds all day. I don't want to deal with clots.
Yes. Any any last words from my co-hosts and co-panelists? I was told that we only have 3 minutes left. I will start with Calvin first.
Thank you very much for the nice demonstration. I was actually wondering if there's a practical video demonstration of the proximal seal technique, because although you mentioned, I think whatever you said happened in a few seconds or within a minute anyway. So it might
there should be. I think Perry can probably share with several videos with you about the proximal seals. Yeah, love to share anything that you like to have.
Great. Dr. Sunu? Thank
you. I agree with Dr. Razali regarding the mindset of segmental approach in cryoballoon ablations. In my opinion, previously I still have mindset that we should do complete occlusions to achieve a best result of the PBI solution. But in this lecture from Dr. Su, I learned out, and I will try to apply this on the next patient. Thank you.
Thank you. Dr. Chan?
Thank you very much. A very nice presentation. And actually, it gives me more thought about, now I try to do a little bit segmental operation, but it is very encouraging, and it seems technically it is feasible to make more tailor-made segmental operation, especially by the eyes and also the 3D system. So let's see, and it can improve the outcome, and we can do it better.
Yeah. So with that, I would like to close this session, and I would like to thank Dr. Wilbur Su, of course, for spending time with us. Again, as usual, every time we listen to you, Wilbur, we take there's a lot of learning process. And as you said, this thing is an evolving science, and we do appreciate your work and your effort in advancing this science. Thank you so much for your lectures and for sharing with us the videos. And for those of you who want more videos, I just ask from Perry. I think he will be able to share some other, like Calvin Wong wants the proximal seal technique and things like that. So I would like to thank all my friends and panelists. for participating, and all the audience for asking great questions. So with that, thank you everyone, and have a good weekend. Bye bye.
Hey, thank you so much. Such an honor. Thank you.
Thank you. Bye bye.
Bye now.
We done?
Okay, we are going to end this webinar in 3 minutes. Yeah, if you have time, feel free to share your thoughts through this QR code. Yeah, we will have a Google form for you. Yeah, for the surface for this webinar. Thank you so much.